Andy Cotgreave, technical evangelist at Tableau and co-author of the Big Book of Dashboards. This is your first time watching. We're trying to find interesting, deep stories about data and how it's being used across all spheres of life, media, politics, science, business, everywhere else. Our goal is to help you take what we find and apply those into your own data use in work or in personal life. This week, I'm delighted to be joined once again by Amanda McCulloch, Senior Data Visualization Lead at Exceller and Operations Director at Data Visualization Society. Welcome back, Amanda.
Thanks, Andy. Happy to be here.
Great to have you. And we also have a special interview today. In a while, Steve Schwartz will be interviewing Jennifer Tolbert from the Kaiser Family Foundation about health, public policy, and the business of care that is being reshaped by COVID-19. But first, we're going to start off by looking at some data visualizations that have been making the news and changing the stories in the media this week. You ready to go, Amanda?
I'm ready, Andy.
All right. So today I wanted to talk, Amanda, about a new chart that I think we're going to be talking a lot about in the future weeks. I think it's going to become... So the charts in mind are talking about excess deaths. So for me, and I'm sure millions of other people, that is a new metric that we've not had to experience before. Well, what does excess deaths mean? Let's look at the chart and we can explain what it's about. What we're looking at here is the number of confirmed weekly deaths in England and Wales. I'll break this down piece by piece. The dark line is expected deaths. That is the number of deaths we would expect to see in a normal time period. The area chart underneath is the actual number of deaths as reported by, in this case, the Office for National Statistics in the UK or in England and Wales. Now, this is really important because the number of daily confirmed COVID-19 deaths and the actual number of people who die from or with COVID-19 are different. And that's really the power of this chart. We're going to come back to that in a moment. And I'm sure, Amanda, you've got some opinions on that too. But to me, the insight becomes clear as I start experiencing this chart. All the deaths over here on the right-hand side are excess deaths. They're above the expected death baseline. So they're people dying in numbers larger than we might expect. And then the Economist breaks this area chart down and adds a red area, which is the number of deaths currently attributed to COVID-19. And that is changing retrospectively. But this is where I think the data communication aspect really comes to the fore, because now we know the chart, for me, some real insight pops out. What my eyes are drawn to is how I'm focusing on the gap between the expected line and the actual deaths. And as you can see in England and Wales, it is really pretty big. But more fascinating for me is, well, look at the size of this gap. This is excess deaths not attributed to COVID-19. And here in this small part of the chart is where I think the real nugget of the story is. What is causing these deaths that are not attributed to COVID-19? Media reports in the UK suggesting it might be people with serious illnesses who are not going to hospitals, possibly because they've been told to stay away. Or it might be COVID-19 deaths that have not yet been attributed to the virus. I don't really want to get into what is the right or wrong answer here. I just want to talk about how I've responded to understanding these charts and the focus on that section. But when you go and check out the Economist article, that wedge is fascinating. On the left-hand side, we're looking at New York, and you can see that the red is accounting for all the excess deaths in New York. They're all COVID-19. Contrast that to Istanbul in Turkey, where only a small proportion of excess deaths are currently attributed to COVID-19. And it's very natural to start thinking, well, why? What is happening? What are the reasons for this? Within the article itself, they've got loads of countries and loads of different regions. And I had a really interesting relationship with this chart, because as I understood the chart and understood all the context, I found myself, as I was reading this chart, focusing in just on this tiny wedge. So then I think, well, as this chart evolves, what is the right way to evolve this chart? And really, for me, this is possibly not as applicable to COVID-19 situation, but more applicable to business analysis. This is the part of the chart that for me contained the really deep, rich insight. And it only covers 5–10% of the real estate of the chart. Could we not just plot the excess non-COVID deaths on their own? So this has two advantages. First of all, it, for me, focuses on the part of the chart that I think has the best insight, not the best insight, but just the insight I was seeking. It also puts the expected deaths on a horizontal baseline, which means it's a lot easier to compare change over time and to compare different countries. And for me, considering which part of a chart is or isn't the most important is a really important thing to learn about when building a data culture. Because here, what The Economist did in the article was add all the context for the data. They introduced these new concepts of excess deaths with lots of context to explain the chart. And then, for me, if I was the end user, because I found myself focusing just on that tiny area, I'm like, well, could we possibly simplify that chart in response to my evolving needs as I think, well, what's the key insight I want to draw out of this chart? So that's my personal take on this. I think it's been fascinating seeing this data reported in the media. We've got The Economist taking the lead, New York Times, FT, and I'm sure many, many more people will be talking about this concept of excess deaths in the future. Working out and thinking about how to evolve charts for your end users' needs is something that's been key for me, what I've learned over the years working with Tableau. But go check out the links. Do let us know what you think about this. And Amanda, I'm sure you've got some good comments to make on my little missive this week. What do you think?
So I think from a visualization perspective, you call out the fact that it gives us an aligned scale, which can make it easier to compare even in that small multiples view. But as a public health professional and as someone thinking about how we pull out different segments from, say, an area chart, I actually don't like having this pulled out separately right now. And there are a couple of reasons around that involve helping to understand and see the context within which those data points are unfolding. So I really appreciate that in the Economist charts, they've provided me with all the context I need to understand the burden of mortality in these different countries, to understand the shape of the trends, to go ahead and see what those different segments look like, and to focus, as they have, on this kind of story of the excess deaths that we can attribute to COVID-19. I think it's a bit misleading right now, though, to pull out that additional small segment between the reference line and those COVID-19 deaths, because there's so much we don't know about those, right? We don't know how and why they're happening. We don't have a lot of context to wrap around them, and we can make some best guesses, but we don't know that those aren't COVID deaths. So maybe they should be staying in that other category. We also don't know kind of what they're attributable to. And so I actually worry a bit about pulling this out and displaying it so simply, but without the context. And I think that's something we can think about regardless of what we're visualizing, is kind of where are we choosing to limit the amount of additional data we're plotting in a chart to provide context versus putting it separately, say in some text or some footnotes, because you could add some of these additional pieces of information there. I just don't think that they'd be as immediately accessible to people as they are in the chart here. So right now, I would lean away from plotting these separately. I think the interesting intermediary chart you've created on this view is calling out that segment that you have where you've actually color-coded the segment between the reference line and the COVID deaths with a different color. And to me, that calls out and visually emphasizes that segment of the chart more and draws my attention to it in a different way without taking it out of context. So maybe we can find some kind of happy medium where we can look at that together, because I do think there's value in being able to compare that segment of the chart more easily across the different countries or cities. So as we continue to evolve our analytics and analyses of what's happening, we can look at and compare different groups of countries or cities, urban, rural, looking at different demographic populations, looking at LMICs and what's happening in less resilient health systems. So I think you've maybe come to, I'm happy with your intermediary step more so than wanting to jump over to that oversimplification in my mind.
Right. The challenge here, what's fascinating here is you and I are two different individuals with different backgrounds, different thought processes, different demands of data, right? And this context, the right amount of context is so hard to try and design for when you're in a business environment. If the question was framed around how many deaths have we not yet categorized, then I think I would defend my pulling this information out. If the question is, how many deaths are not attributed to COVID-19 and within the context of everything else, then of course you're 100% right. And that's the sort of the path we always have to tread as communicators and designers, I guess, trying to work out who's going to consume this and what's the question they're going to ask.
Well, and maybe is the piece here is how do we kind of evolve our different analysis tools to enable people to make that choice where they can drill down or focus more on different segments of a chart. I could see wanting to put this on an aligned scale and calling it out. I just think that there's enough uncertainty still in this data set because I just struggle to pull any of these charts out of the context of kind of how we would look at them from a health perspective. And there's just enough uncertainty in this data set that pulling it out and simplifying it that much makes me nervous. Because I think one of the challenges we faced in understanding what's happening in the world around us now, but also always, is simple, easy to read charts are eye-catching and great and really useful for kind of seeing kind of high-level, big picture ideas and trends. But then do they give us enough information to make those relevant and actionable for us as individuals or as communities? And I worry a bit about when we oversimplify information that visually, that it kind of reinforces that it's something people should look at and believe. And we've seen research that shows that power of visualizing data more so than plotting it in tables or in text.
Okay. Well, great. Thank you for the comments. I'd love to know people watching. Let us know what you think. Which one would you rather see? All the context, or just drill in? But then also think in business, how does this kind of thing apply to your daily work needs as an analyst or data leader? Well, thanks, Amanda. The good news is we also have a very special second interview today. I'm going to hand it over to Steve Schwartz, one of my Tableau colleagues, and he's going to talk to Jennifer Tolbert at Kaiser Family Foundation about health and public policy. Over to you, Steve.
Thanks, Andy. I'm Steve Schwartz. I head up public affairs for Tableau, and today I have the pleasure of chatting with Jennifer Tolbert from the Kaiser Family Foundation. We're going to spend a little time talking about health and public policy, really the business of care that is being reshaped by COVID-19. A lot of the policy decisions are driving the experience a lot of us are having with COVID-19. It's the shelter-in-place orders, it's business and school closures, even how and when we can run out and grab a bite to eat. Jennifer's the director of state health reform at Kaiser Family Foundation and is the associate director of their program on Medicaid and the uninsured. For those who don't know, KFF is a nonprofit organization focused on health issues, filling the need for trusted information on, among other things, national health policy issues. Jennifer, why don't you give a quick introduction to your work and talk a bit about how KFF is using data to keep the public informed about these efforts?
Yeah, thanks, Steve. It's a pleasure to be here today. So thanks for the opportunity to talk about the work we're doing here at the Kaiser Family Foundation. As you said, we very much engage in health policy issues, the critical issues facing our country. And obviously, when the coronavirus pandemic hit, we immediately turned from all of the work that we were previously doing, monitoring things like health insurance coverage and healthcare costs, to really focus on COVID-19 and the country's response to the pandemic. And so in terms of the work that I do, one of the things that I've done over the years is to monitor state implementation of whether it be the Affordable Care Act or state level health reform efforts long before that. And so I felt in this particular situation, given that a lot of the work was a lot of the response was happening at the state level, one of the things we wanted to do was to develop an interactive state data tool where we would pull together all relevant information and data related to COVID-19 in one place. And so we've created this tracker. We call it informally a tracker, where we're monitoring things like cases and deaths and testing rates and hospitalization rates, but also looking at state policies around social distancing, their efforts to flatten the curve, if you will, and reduce the spread of the virus. And then also actions that states are taking to facilitate access to care by eliminating or lowering cost barriers and other barriers to people accessing the care they need.
That's fascinating. So, you talked a lot about a lot of the metrics you are looking at and the data you do have. I actually want to ask off the top, how are you approaching a lot of the uncertainty that you're finding in the data right now? I think, specifically testing data, it's something we have very little of right now. How is that sort of shaping how the work you're doing, how effective you think these policy actions can be?
Right. So, as this whole situation has evolved, you realize the incredible importance of reliable and accurate data. And, in some areas, we certainly still are lacking that data. And as you note, testing is one of those areas. We have been collecting at the state level, and I should note that there are some data and information that we are collecting ourselves here at KFF, and then others that we are just relying on others to collect, and then we are reporting and putting on our site. And so the testing data is particularly problematic. We're not where we need to be as a country in terms of the level of testing to be able to understand how far-reaching this virus is, and really to understand who remains at risk and what we might be up against as we think about kind of reopening the economy or easing some of the social distancing restrictions that have been put in place. And so in the face of that data and the kind of lack of data around testing, what we've tried to do is just collect as much other data as we can and provide as much information as we can to try and paint that broader picture. So information around cases and deaths, as well as hospitalizations, and other information around who might be at risk. Those are the kinds of pieces of information that we are trying to pull together. And again, I will say that we are looking for and adding data to our tracker as we can. And even, if it's not exactly as reliable or as accurate or as comprehensive as we want it to be, our feeling is that some data is better than no data. So, we are posting the testing data that we have available, recognizing that it is, still somewhat limited.
Yeah, and I've heard that sentiment of, some data is better than no data in a few places. And I think we're all groping for some sort of something to anchor ourselves on right now. But so you also mentioned flattening the curve, as a goal of all of these actions, and which I imagine makes evaluating hospital capacity just a really critical insight. So how are you and your colleagues evaluating that hospital capacity? And are there sort of policy actions that you've seen help improve some of that capacity?
Yeah, so we obviously, as this whole situation has evolved, we began to understand very quickly that hospital capacity was going to be a key to the response and the ability of localities to respond effectively to outbreaks. And so, we're all learning a lot in this process. And so our focus on hospital capacity has certainly evolved even over the course of the 6 weeks that we've been monitoring this. But initially, we focused primarily on beds and things like ICU beds in particular, as well as equipment like ventilators. And because that seemed to be the focus, it was really about what was the existing capacity. But we realized quite quickly that that was going to be insufficient. So there was another component, which was, staffing. how like you may have hospitals may have beds available or even excess beds, but a critical factor would be what is their staffing level, and in particular among the critical care workforce. So people who could staff those ICU beds, who could run those ventilators. And so, we began then looking at that issue, the staffing issue, and then quickly realized that, well, even given whatever existing limitations may be in a local area, that there is surge capacity, and states have responded quite quickly in setting up, field hospitals and getting those staffed by bringing in resources and staff from other parts of the state or even out of state to help expand capacity. And so, it's been, I think, important and informative to watch how this has evolved, and to be able to reflect all of that information. I will say we are still on our tracker a little bit behind in terms of the information that we're producing. We're still looking only at beds, staffed beds, as well as ICU beds, that we have done some analyses looking at rural and urban capacity. We are in the process of collecting data on that critical care workforce. And I think then the next step is to be documenting that surge capacity that we're seeing expanding and evolving in many communities throughout the country.
Yeah, and I think some of that surge capacity came through, I believe they're called the 1135 waivers that a lot of states have been using to bring folks who haven't traditionally been part of the workforce, the care workforce, back into service. Is that right?
Yeah, so there is a mechanism that states can take advantage of in an emergency situation when there is a national emergency that has been declared, and they can apply for what's referred to as an 1135 waiver. And this allows states to waive certain requirements, particularly for federal government programs, so for Medicare, Medicaid, and the Children's Health Insurance Program. But what it does is, particularly when it comes to provider capacity, it allows states to employ some flexibility around things like licensure, or allows them to bring licensed providers from out of state to provide care and work in a given state during this emergency. So that has allowed states, nearly all states, I think there's only Ohio is left to actually receive approval for one of these 1135 waivers, but it is allowing states to kind of to loosen restrictions around workforce issues as a way to be able to build up that workforce, and particularly enhance the workforce in in particular areas around critical care to respond more effectively.
Yeah, and I would imagine that's going to be probably a longer tail, but the data and the study around that work, or the impact of those waivers, is going to be fascinating when we get the chance. So let me transition a little bit. We've got this set of policies in place, and we're starting to see trend lines starting to flatten in some places, and policymakers are starting to talk about, when do we reopen the economy? From a health systems performance perspective, how are you looking at it? What metrics are you tracking, and what should we all be looking for in knowing when it's time to start easing back in?
Yeah. So I think this is a really important issue, and we're already seeing even as of yesterday, in fact, we added it to the tracker today. A handful of states have announced that they're reopening certain businesses now under certain circumstances, and they're trying to lay out the requirements under which these businesses can reopen. But I think there is intense pressure for governors to begin easing these restrictions. But at the same time, they're trying to balance this need to sort of reopen the economy against the need to maintain the public's health. And so what we've seen so far is a number of governors have laid out some measures that they need to see in place before they will begin the process of reopening their economies. And so, broad-based testing, we'll come back to testing again, where we started initially. I mean, that's essential to being able to ease these restrictions. Having community-wide testing and all of the resources available to test and related to that, contact tracing. So as outbreaks happen, because we know as these social distancing measures get eased, that hotspots and outbreaks will occur. And the key is going to be, how do we contain those? And you can contain it by contact tracing, by really identifying people who are sick and then making sure to let everyone know around them that they need to quarantine, and kind of monitoring that activity. In addition, states are looking at that hospital surge capacity. What do they have in place? Will they be able to meet the demand as the number of cases begins to increase again, or increase at a slightly higher rate again? But I think, we're also looking at what is occurring in terms of cases, particularly new cases and new deaths, and what does that daily increase look like? And I think many governors are saying we need to see a 2-week decline in the number of new cases before we feel it's safe to reopen things or to begin to ease these restrictions. So those are some of the, the data points that that certainly the governors have said that they are going to be looking toward. And so we are trying to capture those data on our site as well.
Yeah, and that's actually a good jumping off point. It is something else I wanted to ask you about. It's kind of at the intersection of your specialty and the intersection really of where KFF sits, and not just looking at the public health and public health response, but also the economics of our healthcare system in the United States. There's a trio of policy actions that have already taken place that really cover interesting parts of that response. It's testing, which we've talked quite a bit about. There have been sick leave policies, and then there is this sort of on the horizon, the potential of vaccines and where we're headed, and there are already policy actions being taken in that direction. Both the Families First and the First CARES Act, legislation set up regulations for what's covered and how, but I have to imagine it's not that simple. On testing, you hear, what's being covered. And do we have a sense of what the cost is going to be? Yes, everybody can, on the surface, be tested, but, like I said, it rarely turns out that way. So, what should we be looking for in the data there, and what are you seeing?
Right. Yeah, I think that's a really important issue. I mean, there was a lot of focus in this initial legislation around ensuring people can access testing. So there were the initial requirements that all private insurance plans had to cover testing, diagnosis, and testing. So that office visit or the emergency room visit along with the actual test itself. But beyond that, so it's one thing for the insurers to cover it, but again, there is a cost to most consumers who have deductibles or co-payments. And so the next step was to eliminate that cost sharing for people with insurance. But then the question, what do you do about people who don't have insurance? Those who are uninsured. So then there was a legislation again, or provisions that would provide for free testing for people who are uninsured. So I think that's all well and good, except that, what do we know about what's happening on the ground? And I will say my colleague has done some great work, though somewhat unscientific at this point, not really comprehensive, but looking at and making some calls to find out at testing sites kind of around the country, what are the policies around what is the cost? Are they charging people up front? Are they billing insurance? How is that all working? And I think her findings have been really interesting. What she's found is that some places are providing free testing to everyone, regardless of your insurance status or lack thereof. You can just come in, you can get the test, and you're not billed, and you just will get the results when they're available. Other sites, however, are charging, and some are requiring that payment up front. And then, as with everything in our healthcare system, those costs are ranging pretty widely. She identified costs as low as $59 per test to $229 per test. And then in terms of, people who are uninsured, even though these providers are able to get, according to the legislation, are able to get reimbursement for those costs and therefore should not be billing people without health insurance coverage, there's not yet a lot of guidance on how that reimbursement will work. How do you apply for it? What exactly codes do you need to submit, and how do the claims work? And so what she found was that, in fact, some of these testing sites were charging people without insurance and requesting payment up front. It's not clear if those individuals pay up front, whether they will, get reimbursed for that cost. So I think there's a little bit of a breakdown between the policy and what's actually happening on the ground. And I think documenting those issues is real important, and important for as much for learning about what's happening now, but also for understanding what we can do better the next time this happens. And we can hope it won't happen for a long time, but I think it's inevitable that it will.
Yeah. No, that's I have to add that transparency, data playing that really critical role in the moment, and then after the fact when we're going back and examining, to exactly your point about what we could be doing better. And I have to imagine this extends too to the sick leave policies. Congress has this mandatory federal emergency sick leave program, but that has to be an area too where you're keeping an eye on certain indicators, certain metrics. Would love to hear a little bit about how you're thinking about tracking that policy and its effectiveness.
Yeah, I think this is a really important policy as well. As you know, the United States, prior to this coronavirus pandemic, one of the few industrialized nations without a federal sick leave policy. And at that point, many states also did not have state mandated policies. So it was really left to employers to establish these sick leave policies. And, many have done so, but many others have not. And particular gaps exist for low wage workers and people who work part-time. So as you know, in the Families First Coronavirus Act, there was a federal temporary sick leave policy that was established that will run the duration of the coronavirus pandemic and provides some limited benefits to workers. But I will say, I think limited is very key here. Eligible workers, and it doesn't apply to all companies, just companies with fewer than 500 workers, will get 2 weeks worth of sick leave, paid sick leave, if they either contract COVID-19 or are forced to not work because they've been asked to self-quarantine for one reason or another. But that's only 2 weeks. What we know about people who do contract the virus and end up with a more severe case is that they can actually be out of work for 6 weeks or more. So I think, monitoring, I think this is an important step and an important safety net, but it does not completely fill the need. And importantly, it doesn't apply to many of the workers in the gig economy. So in order to get paid sick leave, you have to be attached to a former employer who provides you those benefits. And so many of these gig workers do not work under those kinds of arrangements, and so would not qualify. So one of the things we're tracking is what have states done in terms of having mandated sick leave policies. But again, I think this is another instance where we're going to want to look back once we get through this and see what worked and maybe what could be done better or differently in the future.
Yeah, no, absolutely. It's fascinating. And this is sort of in the moment decision making. One of those areas where we are seemingly a step ahead is when it comes to vaccines. I mean, very much under development right now. But fingers crossed, there will be a day in the relative near future where they are available. And it sounds like there's some dimensions I've read about with the Affordable Care Act where this will actually influence how that process plays out. And, what are the considerations as you're thinking about the ACA and its vital services coverage? And then how are you monitoring the effects of what that policy, how it's shaping the response? Could shape.
Yeah, so I think, again, the federal legislation does require that a vaccine, when it is developed, be provided free of charge to people with private insurance. And I think this is an important place where we are building on provisions in the Affordable Care Act. The ACA requires that preventive services that are rated A or B by the U.S. Preventive Services Task Force are covered by health insurance policies at no cost to the individual. And so many vaccines, proven vaccines, are covered at no cost. So you can think of the flu vaccine for adults, but all of the vaccines and immunizations that children receive. And so I think this will fit nicely into that. And because we have that experience as consumers and as enrollees, we know that that vaccine should be covered free of charge. And it will be much easier for insurers and other plans to implement that policy because we have essentially that policy in place already as a result of the Affordable Care Act.
Yeah, I noticed on your state policy actions page, one of the things you're actually tracking is what this performance looks like in states that have expanded Medicaid and those that haven't under the ACA. So, I will be judicious of your time here, and I really thank you for everything, all the time you spent with us. What's next for KFF, and how is the data, going to play a role in that exploration of this issue and all of the after effects?
Yeah, I think, even as we're sort of in the thick of this, we are already thinking about what comes next. And, what I will say is we are going to continue to monitor all of the things that we're monitoring right now. I think that's going to be really important. Again, this virus is going to be with us until we have a vaccine that's going to be broadly available to folks. And so we need to continue monitoring outbreaks, cases, and deaths as we go forward, and particularly as we try to return to some sort of normalcy. I think it's going to be what we know is that these kind of social distancing measures that have been put in place may need to be reactivated as things are eased, we start to see some hotspots in key areas or even maybe a broader outbreak. So we're going to continue monitoring all that we're monitoring right now, and hopefully some of the data and the reliability and the accuracy of the data will improve. But I think, we're also going to want to be, at the end of all of this, we're going to be looking back on what happened and how this played out, how the gaps in our current healthcare system, for example, exacerbated things like racial and ethnic disparities and how this virus has affected people. And to do that, we're going to rely on all of the data sources that we have in the past. The American Community Survey, which we use to look at health insurance coverage, some like the Medical Expenditure Panel Survey, which looks at healthcare costs. And some of the surveys that we conduct at KFF, we have a lot of those on hold right now because of, just bandwidth, and we can't go survey Medicaid directors at the moment because they've got other issues that they're dealing with. But again, once things slow down, we're going to need to get back into the field and talk with them about how things went and kind of what they're dealing with. So data is going to play a really important role in all of this going forward.
That's great. Well, I appreciate, again, you spending the time with us today. And I encourage everybody to check out kff.org to see all of the work being done around state policy actions, but the broader evaluation of what's going on in our healthcare industry in the United States right now. Jennifer, thank you again for spending some time with us, and we'll chat soon.
Great, thank you.
Back to you, Andy.
Okay, Steve, Jennifer, thank you for that fascinating interview. And Amanda, thanks for our great conversation about the chart at the top of the episode. Thank you, everybody, for watching today. We hope you've enjoyed it. Please leave some comments. Let us know what you think. Let us know whether you agree or disagree with the things you're seeing. What's it made you think a bit more about? Also, if you want to go and find out more, do go check out the Tableau Data Hub. We've got loads of resources you can download there. If you want to do some free e-learning, Tableau is making e-learning free for 90 days during these unprecedented times. And then do follow us on social media. Tableau can be found on just about all channels. That's it for today. Wherever you are, we hope you're staying safe, having fun. Thank you for watching, and we'll see you next time. Take care.